So good evening, everybody. My name is Michelle Rousseau from Advanced Orthopedics. I'd like to thank you for joining our second episode of the South African Direct Anterior Approach Interest Group meeting. And a special welcome to our panel who appreciate your involvement and taking the time out to join the discussion tonight. And for those of you who missed the first episode last week, a recording can be accessed either on the Advanced Orthopedics LinkedIn or Twitter sites, or on the Tygerberg website. CPD points will be available in mid-September for those of you who are interested in that. So last week's introduction explored the concept of DAA and reasons to consider introducing this technique into your practice and some of the learning curve challenges faced by the panelists who've already adopted the technique. So we look forward to the contributions this evening from a purely academic perspective, and we'll explore the evidence for and against the technique. And we trust this will bring about some lively debate, and also look forward to your questions, which can be sent to the panel via the Q&A button at the tab at the bottom of your screen. So we'll do our best to answer all the questions. And without further ado, I hand you over to our chair this evening, Dr. Hans Jacobs from the Department of Orthopedics at Steve Biko Academic Hospital in Pretoria. Thank you, everybody. Over to you, Hans.
Thanks, Michelle. Let me just share my screen. So, welcome, everyone. This is day 2 of our Anterior Approach Interest Group virtual program. So, tonight is a very academic night, which I'm really looking forward to. We'll try not to bore you too much. I'm very excited. It all boils down to this. We'll have a look at the literature and see if we are being led by a fashion trend, or are we actually improving the patient's outcome. So we're gonna run tonight similar to a court case where we have we'll have Yurik giving us the opening arguments and laying down what the registry say about the approach you use in surgery. Then we'll have the opposing arguments by Dr. Manjra, and then the supporting arguments by Dr. Johan Charlo. So I'm really looking forward to this. And without further ado, I'll introduce our panel. Firstly, I just want to urge everyone to visit the north of our country. I know everyone always talks about the mountain. But if you look at the picture, we have things up here, unlike popular belief, apart from the Blue Bulls rugby team that can blow your breath away. So please visit us. We'll do some surgeries and talk a bit of orthopedics. So then our panel, I'm really honored to have you guys as my panel tonight. Dr. Koos Jordan is the consultant in arthroplasty at Tygerberg Hospital, and he also hosts a fellowship. He actually trains fellowships, trains surgeons like he's got like a DAA factory down south there, so he makes it difficult for the rest of us to build our practices. So thanks, Chris, for being here. I have to say, like me, Chris is a farm boy. So if you struggle to understand him, just please let me know, and then I'll ask Yurik to translate it for us. Secondly, I've got Dr. Johan Charlo. He's one of Chris's previous fellows. He's in private practice now, and he's also associated as a sessional consultant to Tygerberg. Welcome, Johan. And then Dr. Mohammed Manjra. He's all the way from Toronto. Welcome, Dr. Manjra. He was one of my junior registrars when I was a senior reg. He's doing his 2nd or 3rd fellowship. So you'll have an interesting input from Toronto's side. He's actually just arrived there. So he just finished his quarantine period. Welcome, Dr. Manjra. Then Dr. Chakic. He's probably one of the highest volume surgeons or anterior approach surgeons we have in South Africa. So it'll be nice to have his input. He's in private practice and also associated with Wits University. He's got a great CV. If you have time, please read his CV and please visit him if you want. Thanks, Dr. Čakić, for giving us your time. Then last but not least, Dr. Jurek Pitzrak. He's also done a few fellowships, one under Dr. Faris Haddad, or Prof. Faris Haddad from the UK. And he's also got a lot of experience in all the approaches. And so if you want to know the downside of approach or the upside of approach, he's done all of them. So it's nice to have you on the panel, Dr. Pitzrak. So first up on our presentations, we're going to ask Jurek to tell us what the registry say on the approach. So Jurek, please go ahead. Maybe in the meantime, Jurek, you can tell the audience what approach you're currently using mostly.
So at the moment, I'm a posterior approach surgeon, and that's really due to the fact that I do a lot of pretty technical and the more difficult total hip arthroplasties, but I do a lot of hip replacements with Dr. Čakić, and I'm always amazed at how beautifully and technically gifted he is, and certainly how well his patients do. So I certainly would see myself as a direct anterior approach surgeon who's stuck in a posterior hip approach world. Okay, so I'm actually going to talk about the current standing of the direct anterior approach around the world, and then hopefully allow the audience to understand where the chaps after me come in. So over the recent few decades, we've actually seen this increased move towards a less invasive surgical approach in all surgical disciplines, actually. And we're seeing a vast increase in endovascular surgery, laparoscopic surgical procedures, and even our trauma orthopedic cousins are using percutaneous approaches far more regularly. And this has spawned an increased concurrent interest in total hip arthroplasty, in which our surgical approaches have tried to decrease the dissection of the soft tissues, all in the hope of improving the overall clinical outcomes, to limit adverse events, and to get happier and far more satisfied orthopedic patients. So what generally shapes the surgeon's thinking when deciding about which approach to use and how to shape their future? Well, it's really the literature and research that they're reading and that they're seeing. It's registry data. It's all the academic meetings, courses, and congresses that we go on. And it's also our colleague interaction and the experiences that we share on formats and forums like this. So if we have a look at the top 100 most cited articles on total hip arthroplasty, it showed that the number of citations in these top 100 have ranged over the past from 191 citations per article to 994. In the 1990s, there were 46% of these top 100, in the 2000s, 47%, and lately, we've really had very few. These top 100 articles have generally come from 15 countries, of which America and Western Europe have contributed the rest. And really, it's these two areas that are shaping our thinking, shaping our practice, and of course, shaping the way in which we are moving in our practices. What we do see is that there's an increased interest, an increased publication, an increased following on surgical methods and materials and new method evaluations, of which surgical approaches like the direct anterior approach certainly fall part of. When we have a look at the National Joint Registry of England, Wales, and Northern Ireland in 2017, there's still a vast preponderance of surgical approaches being done via the posterior approach, with almost 60% being done. Lateral and Hardinger approaches was 35%, and the anterior or anterolateral approach was less than 1%, with other, like the superior and posterior, coming in at almost 5%. So when we have a look at the analysis of current practices from reviews of joint registries, such as the United Kingdom, the oldest in Sweden and New Zealand, it shows that most surgeons are still posterior approaches, followed by the lateral approach, and almost less than 5% in these big established joint registries are using the anterior approach. In this paper, recently published in 2019, having a look at 17 national European joint registries, regional Italian registries, and 4 other regional European registries across Europe, including almost 3.1 million total hip arthroplasties and 25 million total knee arthroplasties, it paints a very similar picture. What it does show is that the data captured in this registry is a great deal to do with the surgical approaches, with very few registries, especially those in the regional areas, not capturing the approaches. As you can see, it's really the method of fixation only that is captured far more regularly. What we do, however, see is that across Europe, there is significant variation in the total hip arthroplasties, with the posterior approach being used less than 20% in Switzerland and Eastern Europe, while in places like Sweden, Finland, Denmark, France, and Netherlands, it's used in almost more than 50% of all surgical total hip arthroplasties. But this interest and this concern and this appetite for direct anterior total hip arthroplasty is also seen across the world and also in our Asian countries. In this paper, in which they did a PubMed search for direct anterior approach and total hip arthroplasty in Asian countries, they found that 59 articles, or only 12.8%, came from this area. What they did show was that the number of published articles on this topic averaged about 3.92 publications per year until 2014, when their appetite was whet and there was a significant and almost dramatic increase. Before, it was 1.1 articles per year, and after 2014, almost 7.1 articles from Asia dealing with direct anterior approach. In Japan, there's a great deal of interest, with a vast majority of papers from Asia coming from there. This data, however, does have to be taken with a pinch of salt, as I doubt we could argue that Israel and Turkey are really part of the Asian continent. When we have a look at the American Academy of Hip and Knee Surgeons experience, they did an audience poll in 2018. The first such poll was conducted in 2009 and at their biannual meetings thereafter. The 2018 meeting included 920 fellow members of AAHKS, as well as 540 non-members who were present, who did not include non-industry representatives. What it did show, once again, coming from America, and we know that the Americans are more likely to influence our thinking, is that there is an increased use of direct anterior approach. In fact, in 2010, only 12% of respondents used the direct anterior approach, but by 2018, it had increased to almost 40%. In this study in 2018, they did a similar audience response, except they dealt solely with the direct anterior approach. They did an electronic survey of 2,249 active members to determine the trends regarding DAA, and they found that currently, at that point, 52.6% of their members performed the direct anterior approach, which meant in only 1 year since the previous meeting, the numbers had increased by almost a dramatic 12.6%. It did show that DAA was more likely to be performed in those surgeons who had spent less time in practice than those who did not perform DAA. What is interesting is that only 3% of the current non-performers actually plan to adopt the direct anterior approach in the future, which means that interest groups like ours and companies like Michelle's certainly do have their work cut out for them. Interestingly, it showed that those members who performed direct anterior approach only did they think that the vast improvement was in short-term functional status and the accuracy of acetabular positioning. They didn't feel that there was any dramatic improvement in a long-term functional status outcome, with 85.2% feeling that there was no difference between that and other approaches. The DAA performers in this case, however, felt that they were more likely not to do the direct anterior approach and to preferentially do a posterior approach in cases of revision total hip arthroplasty, complex anatomy, and those patients with an increased body habitus. In an online questionnaire, very similarly, of the members of the Hip Society, they had a response rate of 63%. Much less and much lower, 28.2% of members currently use the direct anterior approach, while 15.4% actually use the Hanna traction table technique. Interestingly, of those that use the direct anterior approach, only 22.5% believe that there was benefit in the direct anterior approach versus other approaches. And even more frighteningly and scarily, 42.9% of members of this esteemed society had actually abandoned the direct anterior approach, with some members having abandoned it at some 300 cases, while the average was 82 procedures. They felt that the most common reason to start the DAA in almost 50% was to accommodate patients' requests, and 1 in 5 surgeons actually started the DAA simply to prevent losing their patients to other direct anterior approach surgeons. In the same vein, and closer to home, we decided, together with my 2 mentors, Dr. Moketi and Dr. Chakic, to do an online anonymous electronic survey of all members of the South African Orthopedic Association. Currently, this paper is in submission, but I will share some of the results with you. We had 208 respondents, of which 7 refused their consent to use their responses, leaving us a response rate of about 29% of members of the SAOA, which we think is a fair reflection because not all members do total hip arthroplasty. We subsequently evaluated the opinions and beliefs of these members to the direct anterior approach in total hip arthroplasty. We found, interestingly, that 39% of respondents said that they are able and do direct anterior approach for primary total hip arthroplasty. When we compared those surgeons who did direct anterior approach with those that didn't, it was incredible that younger surgeons are statistically significantly more likely to embrace this new approach, while surgeons longer in practice, more than 10 years, are statistically significant, unlikely, and wary to change their practice. Surgeons who've done a fellowship, who have probably been indoctrinated by their bosses, are also more unlikely to try a direct anterior approach, preferring rather to stick to their tried and tested surgical approach. When we asked those who did not do direct anterior approach if they would ever start using the direct anterior approach, incredibly, almost 3/4 said that they would not change. When we've tried to see who would not change, once again, it seemed to be younger patients were more likely to change, while older surgeons were unlikely to try anything new. Similarly, surgeons who were longer in practice were hesitant to change, and those with a fellowship training certainly also hesitant to change. So why would South African surgeons not change to direct anterior approach? Well, it seems that Michelle once again has got some work to do, because there's an inexperience in the surgical technique of 31% why they would not change, while the learning curve, although wildly mentioned in all of the literature, only accounted for the reticence of 17%. Almost 1/3 of these surgeons also believed that an alternative approach was better, providing better results and better outcomes. So in conclusion, it certainly is that the direct anterior approach has met the world once again, and there is certainly a global flirtation and fascination. Western European and North American literature, however, may drive our beliefs and opinions, and we should be wary of what the North Americans seem to be telling us. South Africa, however, is following these trends. but much investigation, education, and testing, however, remains. Thank you very much.
Maybe, Yurik, I can ask you, it looks like it's clearly increasing the trend towards direct anterior approach. However, if you look at the UK, do you think a country's health system dictates what approach surgeons use? If they have like a national health system like the UK, the surgeons are inclined rather not to change to a direct anterior approach, whereas the pressure from private practice in other countries tend to leave the surgeons who want to change?
So in my thinking, I think that in places like the UK, and having worked in the NHS, I think they've got their flow, they've got their systems, they've got the way both the surgeons and their support staff work. I think they've got those flows quite well worked out. So I think they're safe and they're happy that their approaches work. If you have a look at it also, I think a lot of the data coming out of it is that there is no real improvement long term. So a lot of the argument may be why change and why risk being flagged by the National Joint Registry, why risk having poor results, why risk having my colleagues question me if there's no real improvement. So certainly we've just had a paper accepted in the Journal of Orthopedics, in which we've had a look at Dr. Chakic's long-term outcomes. And we've shown that there's almost 79% of his patients who've got a 100% score on the forgotten joints score, which is really incredible. So I think we do need to start pushing those envelopes with new literature in order to try and prove that the long-term outcomes can improve. So that's why I think people in those systems would be reticent. Whereas in places like America, I think America really is the land of the free and the land of the brave. And I think there is certainly a competitive spirit that they've cultivated. So I think, as you can see from what we're seeing in that literature, is that they're probably trying to find ways in which they can compete with their neighbor and in which they can compete and grab some of the market share. Good.
Thanks. And maybe I can ask a quick second question. Do you think one should look at registry to decide on an approach where the registries don't tell you about patient satisfaction or patient reported outcomes? Is that not the reason? I know we should look at revision rates, but isn't patient happiness or satisfaction one of the biggest things in thinking about what approach you're going to use?
So I always think we must be very guarded when having a look at joint registries. I certainly believe that you can get a great deal, but there is so much that impacts on how an approach performs. I mean, an approach is an approach is an approach, and it all depends upon the surgeon. It depends upon the implant. It depends upon the patient's experience. And certainly I think that outcome measures are also skewed. So I totally agree with you. Part of it is the fact that we aren't looking at patient satisfactions. We're also not looking at very good outcome measures with a high ceiling effect. For instance, anyone can get a good Harris hip score. It's who gets a good forgotten joint score. That's the question. And that's where I think a direct anterior approach is also starting to separate the wheat from the chaff.
Good. So you're sitting right in the middle. Let's move on to Yuan. Maybe Yuan, you can share your presentation and tell the audience why we should be using the anterior approach.
Thank you, Hans. Yes, good evening. Thank you for the opportunity as well as the introduction. So I've got the easy job tonight to convince some of you to change to the anterior approach, or to just reaffirm to you guys using it already as to why we are keeping on doing it. So I put it to you, Your Honor, is with statistics you can prove basically anything. A couple of wise men said that you can prove the truth or but the truth. So this is not a new approach. It's been around for 139 years. Carl Jutter, the German surgeon, first described it in 1881, and then the Americans got on board and popularized it with the mainstream arthroplasty from the 50s. And then only in the 1980s that the literature started catching up to this new approach. I focused mainly most of the talk on this paper, looking at the 50 most influential papers in direct anterior approach. So this is also a bibliometric or a citation analysis which appraises the impact of the number of citations as well as the citation density per year. Incidentally, 39 of these 50 articles were done in the last 10 years. There are obviously some confounders making it difficult to evaluate literature critically. Only 5 level 1 studies were part of the study. Most of them were published in Journal of Arthroplasty as well as the CORR, and also predominantly focused, as Yurik said, in the Americas as well as in the Europe. In the last 10 years, if you go and look at a Medline search, in the first quarter, the first half, 2009 to 2014, only 128 hits, but in the last 5 years, 518 articles being published on this topic. So these are the 5 level 1 studies that were discussed in this bibliometric analysis. And of note, there's a paucity in the quality and the level of evidence available out there, but unfortunately, this is the best we've got. It's only midterm outcomes. And even the randomized controlled trials have got small cohorts of only 40 patients in each group. And interestingly, these studies mostly compare anterior approach to one of the other approaches. So since then, you know, the research questions have changed. And until about 2017, it was always the direct anterior approach versus the posterior and mainly the anterolateral approach. But since 2017, I think most of the literature is focused more on improving the direct anterior approach. And the questions being asked now is, you know, what is the placement and the longevity of the implants being used? What is the difference between the different positioning of the patient, be it at the traction table, figure of 4, lateral decubitus position? What is the outcomes with the revisions and extensile approaches being used for mechanical and sepsis revisions? What's the difference between the longitudinal skin as well as the bikini incision? And so on and so on. I mean, even the capsule, some people excise it, some people repair it afterwards. I've joined surgeons that put the pedicle in 2 or 3 different positions. There's a lot of leeway this way and that way. We need to see what's happening inside the anterior approach with these things. These are some of the newer articles from 2019, 2020 that's out there. And you can see it's about what's the longevity of the stems and the implants. What is the outcomes with that? What is the outcomes on traction versus standard table positioning? Severe dysplasia and patients with spinopelvic disproportions. You know, these are difficult patients in any approach. So what is the outcomes in anterior approaches? Revisions, as I said, in sepsis as well as mechanical failure. And the subset of patients of the femoral neck fractures is a perfect cohort of patients that can play to the strengths of the direct anterior approach. And more people are looking into the benefits of this now. And a very interesting study looking at the patient's handedness. For instance, this article looked at a right-handed surgeon doing bilateral single-sitting direct anterior approaches on the supine figure of 4 position, and what's the difference between these cup positions on the left as well as the right hip. You know, so these are the things that we're starting looking at. So there's a lot of reviews out there, and I think in the end of it, we need to filter everything out, and we need to say to ourselves, okay, what is there's definitely proven short-term outcomes. A lot of the measurements that are being done, primary and secondary, are equivocal. I reiterate that it's equivocal. It's not worse than posterior or anterolateral. It's the same. And then obviously there are a couple of negatives and a couple of complications that we need to address. And then also, you know, these are usually things that are modifiable and reversible, or if you just pay attention to them. So the things that we know is that definitely the articles out there shows that the gaits compared to the anterolateral specifically is in the short term improved. A lot of gait parameters in fancy labs overseas are proving that. Blood loss and transfusion rates are less. Definitely length of stay is improving, and with the push for same day surgery, I think that's playing into the hand of the direct anterior approach, where we can utilize this shortened length of stay to the benefit. And it's definitely been proven that out of the main three approaches, that the dislocation rates are definitely less. Pain scores are obviously in the short term a bit easier and less, so the narcotic use also less. And then the patient reported outcomes, definitely there's a few articles looking at several scores, and the short outcomes are definitely statistically better, but only up to about 4 weeks. Now you can ask yourself, so what about 2 years outcomes? If you have a neck of femur patient that gets a hip through the anterior approach, 2 to 4 weeks is a very long time for that patient. And that's the difference between life and death sometimes. The inflammatory marker response, because of the intermuscular, internervous plane, there's a lot of research on that actually the inflammatory markers are a little bit better, but some of them are equivocal to the other ones. And then obviously the patients, if they're getting discharged sooner, they're also getting discharged home. That's very important. So less strain on the auxiliary frail care services out there. Looking at the equivocal things that's similar to in all the studies, be it posterior or anterolateral, you can go through those, and then just the bads. I mean, we've gone through the goods. The bads, there's definitely a paucity with regards to nerve injury, but as I said, there's no perfect approach yet. There's definitely but the lateral femoral cutaneous nerve has been quoted as being as low as 0.1% up to 81%. So what that makes you think of as to, you know, are we looking enough for it? And if we're looking at it, is it a long-term problem, or does it go away at 8 to 12 months? Surgical site infection in the obese patient with the pendulous abdomen over the proximal part of the surgical wound has definitely been a concern with dehiscence and leaking wounds. And then again, we'll come back to the learning curve. I think Koos will speak to that a little bit later. But the learning curve has been out there. Some proponents make it as less as 50, some 100, and some even more than 100. And then within the learning curve, that's what skews the literature a bit, is that you have to filter out some of the bad outcomes that is equated due to the learning curve. And we need to be sure that the surgeons doing this and reporting on the outcomes are actually out of the learning curve and not putting in stems in various or undersizing them, giving the approach the fault. So in conclusion, obviously there's no silver bullet yet, be it anterior, posterior, or anterolateral. We have to learn from the mistakes that's been made in the past. We need to know our limitations with regards to this approach specifically. And we need to adapt to the known complications, which are all modifiable, and we can definitely improve on some of that. And we need to get involved in improving the literature and getting the long-term outcomes out there, so that we can definitely back up what we intuitively feel this approach gives to us. So, Your Honor, I conclude putting it to you that the direct anterior approach is here to stay, and we need to embrace it. Thank you.
Interesting. I've got a question for you. It's been a question with me for quite a while, and Dr. Thane Monting, thanks for your question. He also touched on it. So, Johan, if you can put it in short, and maybe Dr. Chuck, you can also add to that after him. What is the long-term benefit of the anterior approach?
Yeah, so as I said, most of the...
just to say quickly, a patient doesn't get a hip replacement every 6 months. So if your recovery is 2 weeks or 6 weeks in your lifetime, does that really make a difference? After that 6 weeks time, what is the long-term benefit, do you think, of the anterior approach?
Yes, so I think the big thing for me is the reduction in dislocation rates. So with the post-operative rehab as well as the lifelong rehab afterwards, is that there are very few functional range of motion limitations to anterior approaches. I mean, the extended external rotator position is a very abnormal position for anything. So I think the long-term reduced dislocation rates for me is a big plus point in the long term. There's only midterm studies out there. So we don't have 20, 25, 30 years to prove that point. But intuitively, if you haven't dislocated, or if the dislocation rates early is less than long term, it should be. So for me, that's a big plus point, especially in the patients that are getting hip replacements earlier and younger, and then will inevitably develop spinopelvic issues with the stiff spine, and then putting a lot of strain on the biomechanics of the joint replacement. So I think in that point, that adds to a bit of benefit.
Okay, I mean, maybe, thanks, Johan. Maybe Chuck, you can add to that. Is there anything else you can add to that?
One of the advantages of anterior approach as a primary procedure, how I see it, is what will be in case of revision, what will be the best way to approach that hip? If you're using a soft tissue preservation anterior approach, you're basically having a open field in the future. You can choose any other approach to sort out the problem of revision, or you can do, when you come to that level, you can do the revision through the anterior approach, completely protecting the whole muscular structures around the hip. None of the other procedures actually allows you that. I mean, we're all nervous going through the posterior approach through the scars because of these posterior structures. And it's exactly the same with the damaging abductors for the anterolateral approach twice or 3 times. The consequences of revisions in the future are very high, and anterior approach gives you that option that those consequences are much lower. And that is one of the reasons why I like anterior approach, because in case if I have to go back, it gives me a virgin tissue essentially.
Cool. Thanks, Chuck. Okay, let's move on. Maybe Dr. Manja can share his screen and try and convince us not to use the direct anterior approach. While you load it, Mohammed, can you tell us which approach they're using in Toronto?
Okay, so the hospital that I'm currently going to is basically mostly anterolateral approach or direct lateral approach, but they are starting to do more anterior approach. So the younger guys have been trained in the anterior approach, but still predominantly anterolateral and lateral approach.
Okay, good.
Okay.
Thanks.
Cool. So I seem to have skipped my my initial slide, but so I'm just going to present what I found in the literature. Disclaimer: I don't necessarily agree with anything I'm saying. I'm just sort of saying what I found. So I've grouped it into certain groups. So firstly, I'm going to look at the systematic reviews and meta-analyses, and what the main things that these were looking at was surgical time, blood loss with resultant transfusion, and then early late functional outcomes, pain scores, radiology, and then complications. So there's 5 articles I'm quickly going to brush through, but more importantly, I want to focus on the conclusion I got from them. So back in 2015, there were 2 systematic reviews and meta-analysis. Both of them had quite a large number of patients, 4,001 and 2,300 in the other. One compared the anterior and the lateral, and one compared the anterior and the posterior. But there also was a heterogeneous group of studies. They both include not only randomized controlled trials, but also cohorts of patients in retrospective and prospective studies. So the lateral study found no difference in complications, transfusions of blood loss, or radiology or serum levels of inflammatory markers. But they did find that DAA had a shorter length of stay, greater rehab, less pain, and longer surgery. And they found the posterior approach, however, had a shorter length of surgery, but longer rehab, more pain, and longer surgery, shorter surgery. The conclusion was essentially that the available evidence doesn't allow them to determine which one is better. But they also did mention that they couldn't conclude much because of the learning curve. The next paper as well, similar studies to the other in terms of blood loss, less with the posterior, less surgical time, longer surgery with the DAA, but still better PROMs and better pain control, but still they couldn't decide. 5 years on, we've got another 3 systematic reviews and meta-analysis, which look at the same topic. Here we look in the initial paper, only 7 studies, 600 patients, but importantly, this was only randomized controlled trial that were included. They found no difference in the length of stay, blood loss, transfusion, or radiology or serum levels, but essentially the DAA that they found was, although it's a longer surgery time compared to the posterior, patients had better early functional recovery. Again, they concluded that there was insufficient evidence, as I may say. Also, Yang et al., similar. And so now I noticed that at this level in the studies, you see that the conclusions start to change. So now, whereas you can't find a superior one between the two, they say they have comparable results. As well as the next paper, also by Chen et al., looking at randomized control trials and non-randomized control trials, it's sort of a bit more objective in the sense that now DA was preferable for early pain relief and functional recovery, but the posterolateral approach had a shorter operation time and less intraoperative blood loss and fracture. So I noticed that the shift in the trend is, as to before, there's no benefit to it, then there were equal benefits, and then finally with this one, we say, okay, well, there's benefits in this way, and then there's benefits with the other one. So you can see how the tone of the studies are changing. So essentially what they were saying is that the DAA, even though it may be longer surgery, you have a lot more blood loss, and your complications of the lateral femoral cutaneous nerve and femoral fractures, you do have a very much reduced short length of stay for the patients, and they have much quicker rehab, and they have much less pain in the acute phase. And with the posterior approach, the posterolateral and lateral approach, you have longer length of stay because patients take longer to rehab. They use much more pain, they use much more narcotics because of the pain, but they say shorter surgery and less blood loss. However, some of the studies also did show a higher rate of complications with the posterior approach. We pride ourselves as DAA surgeons that we are tissue preserving. This was a study which looked at inflammatory markers in the posterolateral versus the anterior approach. But then if you look at the number of patients, 23 versus 23, they had 3 experienced surgeons. They looked at the CK and CRP at different time points, didn't find much of a difference. We all, at times we get complications, we have problems intraoperatively where we need to extend our surgical approach. Historically, the dogma was that it's very difficult to extend it with an anterior approach. That has changed with more recent cadaver study, which was an older cadaver study, which looked at, if you extend it down onto the femur without knowing and protecting that neurovascular bundle, you actually denervate and take away the blood supply of the quadriceps muscle. We look at gait. There were 2 studies which compared gait. The one on the left was comparing with the lateral approach, and the one on the right comparing with the posterior approach. The one on the left, they found that irrespective of which type of gait abnormality they had and what approach the patient had, they still carried on with those abnormalities at 10 months. But also, this is a very short-term study. I don't know how much we can take from also 20 versus 20 patients. Look at the one on the right, 50 versus 50 patients. They found no difference in the locomotor patterns, complications, or the patient-reported outcomes. But they did say that the DAA had slightly longer surgery and more incidence of complications in the form of the lateral femoral cutaneous nerve injury. The lateral approach, receives a bit of critique in terms of, when you cut off the abductors and causing heterotopic ossification. This study compared just over 700 of the direct lateral and direct anterior. They found they didn't have much influence on the short-term incidence of high-grade HO. However, the direct lateral approach did have an increased incidence of low-grade HO. But in terms of high-grade HO, which needed surgery, not much of a difference between the approaches. This was the interesting study I found, and of course, and I always talk about this. We do a study where we compare the posterior approach on the one side and direct anterior approach on the other side in the same patient. And here they interviewed the patients. Even though the functional outcomes were the same, 15 out of the patients favored the posterior approach over the contralateral anterior approach, so more in favor of posterior approach. So I have to mention the study from the hospital that I'm currently going to work at. They looked at all patients over a 3-year period with a 1-year follow-up. Again, just to note, it's a very short follow-up, but they were looking for specific things, so deep periposterior joint infection, dislocation, and revision. As I mentioned, Canada, especially Ontario, is much more of a lateral approach area. Not many people doing posterior approach, very few surgeons doing anterior approach, most of them quite young. And you see that the numbers are very skewed. Only 10% of these were anterior approach and the majority lateral approach. They found that the anterior surgical approach compared with the posterior lateral had a small, but they say statistically significant increase in risk of major complications. The actual numbers were that anterior approach had a 2% complication rate versus the 1% complication rate for the other approaches. And then I think Yurick has already covered this topic, so I'm not going to go into this paper again. But essentially, what I found is that, as Johan mentioned as well, it's very difficult to assess these papers. For one, is that it's a very heterogeneous group of patients, also a very heterogeneous group of surgeons as to how they do the anterior approach. It's not always mentioned. And also with regards to the numbers. I mean, some of these studies have very low numbers. So, it's up to you what conclusion you want to come from this whole thing. But my job was to give you the literature in opposition to it, and I hope I've covered it adequately.
What do you say about dislocations and dislocation rates between the different approaches?
So if you look at the studies that I looked at, the systematic reviews and meta-analysis, not all of them found much of a difference between complications, especially in terms of dislocation. But there were two studies, the two of them were from 2020, which found a higher rate of dislocation with the posterior approach. So I think that we can establish. And then there are studies which I didn't mention because they were studies which concluded and supported, their conclusion supported the DAA, and they showed a significant rate, decreased rate of dislocation with anterior approach. So I'm a firm believer that you get a decreased rate of dislocation in the direct anterior approach.
Good. What was the question, Michelle?
So the question was, if the learning is still so high, are the bad results not due to the learners? Is it worth it?
Good question. So maybe I can ask Chris this. If you were not in public hospital setup, would the transition, would that have been as easy as it was with the pressure from private practice, or what's your experience?
So it's something that we always talk about a lot, is the learning curve and the difficulty in having complications. So as hip surgeons, you're used to having happy patients, and then the transition to anterior approach is not always easy. I want to ask you and challenge you back. Can you remember the first anterolateral approach you did as a registrar or MO, and how did the soft tissue look after that surgery? The first time you operated on a patient's hip, were you really comfortable? And that also boils down to it. So when you learn an approach, there's always those initial periods where some of the patients don't do well as part of the learning. So I work in academic hospital where we train registrars, we train fellows, and some surgeons are not as good as other surgeons. And some surgeons doesn't touch soft tissue the same as other surgeons. There is something to say for cognitive bandwidth. So the more you operate, the more you start looking after your soft tissue, the more you start to care for your soft tissue. But I really are a strong believer that we as teachers of students and registrars and fellows and other surgeons, we must really look at the way that we do the teaching, because the way that it's been done in the past is not acceptable anymore.
Good. Thanks, Chris. We got a lot of case discussions, and I think everyone's looking forward to that. So maybe I can share my screen. Okay, let's look at a X-ray, a neck or femur fracture, pre-op and post-op X-rays. Chris, maybe I can ask you, what is your approach, surgical approach, and your general approach to a neck or femur fracture? Surgical approach, and then what implants do you use? Do you ever do a hemiarthroplasty through the anterior approach? Do you use dual mobility cups? Is it necessary to do dual mobility cups when you do an anterior approach? Do you use cement, uncemented, and criticize our X-ray?
So we in Tygerberg decide between an hemiarthroplasty and a total based on the patient's cognitive function and ability to mobilize prior to the operation. Not as much really with the physiological age or the chronological age. So if patients are cognitive normal and walk unaided, they generally get a total hip replacement. If they are not, they get a hemiarthroplasty. Then the second part of the question is, we do cement still quite a large amount of femurs in Tygerberg. It's between 15 and 30% of all the femurs in the neck of femurs get cemented. And that's based on if it's a door C or if there's any risk of pathological fracture, or if we don't get primary stability with our uncemented stem. And we use two systems, and both of those systems allow us to change at broaching if you decide if you want to use uncollared uncemented, a collared cemented, or a cemented stem. So we make that decision after we finish our trial reduction. So we do 100% of all our neck of femurs through the anterior approach, figure 4 in Tygerberg. If we do totals, all of them get neutral liners 32 millimeter heads. The only time we will go to a 36, and that's because I'm very worried about the torsional forces of a 36 head, is if you go with a cup size over 60. So anything under size 60, you get a 28 or 32 millimeter head. The dual mobility is not something we use routinely. I do use them occasionally, and that's for spinal fusions with patients with stuck sitting position that dislocate anteriorly, like the Angstband patients. They will get then a dual mobility from the start, but otherwise we don't use it routinely. I hope that answers your question.
Yeah, that's a great answer. If I can ask for a quick answer on this one. If you do a hemi or a dual mobility cup, do you find it difficult to reduce the big head through an anterior approach, or are you such a good surgeon, it's always slick and easy, but do you find it difficult if you do a hemiarthroplasty with a bipolar to reduce the larger head?
Yes, definitely. It's definitely more difficult to reduce the larger head. Initially, it was actually one of my challenges, and therefore I used to cut out the capsule for the neck of femurs to allow me to reduce the bigger heads, the hemis or the dual mobilities. Now we've refined our releases, and it's really not a problem. And if you speak to any of the registrars in Tygerberg, they will tell you that we're currently doing probably about 60% of all our neck of femurs as hemiarthroplasties. So that's the default way, most of them. And to reduce the hemi is not a problem at all anymore.
Perfect. Thanks. One last question, Chris, quick answer. Should surgeons start out with doing neck of femurs, or are they more difficult? They should be done only when they are quite experienced in the anterior approach.
Surgeons should get adequate training on how to do the DAA surgery and not venture it on their own. If they had adequate training, it will both cover neck of femur fracture as well as elective surgery, and then they can use the approach according to its merits. But training is more important than the patient. I don't believe in this doing it only for easy patients. You can do it for any patient. Some are more difficult than others. The same thing, fat patients are more difficult with various approaches. Protrusia are more difficult, different approaches. So you can do it for any approach, but I think the training is more important than the patient selection.
Good. Another neck of femur fracture. Maybe Dr. Manjra, you can answer the question here. You can see the inclination on the cup is quite low here. Maybe the anti-version is on the high side. How do you place your cups? Do you use any assisted devices, or is it completely freehand? Is there anatomical landmarks? Maybe you can guide us on how to get better precision on our cup position.
Yeah. So Hans, I trained under course, so I do all my neck of femurs through an anterior approach. And towards the end of my fellowship, I did most of my elective as well as complex and elective through anterior approach. So with regards to the acetabulum, I think the big thing here is exposure, using your retractors correctly. So you need to make sure that you have the retractor that goes over the anterior aspect of the acetabulum. Most of the DAA sets have what we usually call the gooseneck, which goes underneath the acetabulum. And then I use a Holman's that goes over the transverse acetabular ligament. So for me, the guide for anterior approach it's an anatomical procedure. So the anatomical landmark I use is the transverse acetabular ligament. So it depends on the quality of the bone as well, what size I would go to, but I would first identify the transverse acetabular ligament, clean out the pulvinar, and then say, for example, I took out a size 50 head. I would under-ream by about 49, and then ream to about a 50 or 52 cup. But I try and get it anatomical, perpendicular, slightly deep to the transverse acetabular ligament. What also makes it a bit easier in a neck of femur fracture, you don't have much in the way of osteophytes most of the time. So you can use the anterior acetabular wall. Because it's going to make sure you don't ream away that anterior acetabular wall, which is why, as mentioned before, it's important to make sure you have your retractors placed correctly. If you don't place the retractor underneath the acetabulum, the femur tends to push you more into anteversion. I think that's a mistake a lot of people make, is that they tend to antevert and then ream away the anterior wall. So make sure you can get the femur out the way, you You can see your acetabulum, see your transverse acetabular ligament, and then zoom anatomically onto the transverse acetabular ligament. Also avoid going too high. One thing I used to find with the anterolateral approach when we trained in tutorial, that we tend to zoom up into the roof of the acetabulum away from the TAA. When I started doing anterior approach, tend to bring the cups a bit more down and more anatomical.
Good, thanks, Mohammed. Maybe we can go on to the next one, tricky one.
Hans, can I just quickly quickly intervene there with regards to the cup placement in the previous X-rays? Yeah, I just want to say, so you obviously the literature is also full of X-rays intraoperatively, fluoroscopy. So I think in the beginning that we didn't touch anything on that so far. So I don't know, some of the most experienced guys I know also ventured into fluoroscopy intraoperatively, especially on the figure of 4. Even on a traction table, you can do X-rays quite easily to just check your antiversion and check your cup inclination and use X-rays, especially for the more difficult cases. But that is an adjunct to use when you guys using the cup placement, especially in the learning curve.
Perfect. Thanks, Johan.
I also want to come inside there, Hans, please. Can I ask, that is not a classic triple taper cemented stem you've used there. Maybe if I can even ask you and Yurik, what's your opinion about cementing the femur? Do you always use a triple taper classic lateral border Exeter type stem, or what type of cementing did you use for this patient?
So for this patient, we used more than like the anatomic cemented stem, which is called the French paradox. The French love using the stem. So it's nice because it's shorter and fatter, and the access through the anterior approach is sometimes a bit limited. So when we do cement, we use a shorter stem, like in this case, and we've had quite good results. We have done Exeter type cement previously, but it can be in some patients difficult to get a longer stem in. So we're getting quite good results with this stem. Dr. Chuck, you want to say something?
Yeah, I would just a piece of my experience. Put that way, it took me 10 years to come to the conclusion that the best tool in my theater is a C-arm. I start using it only basically after 1,000 cases. And the reason why I did that is because I went to work with Joel Matta, and I thought if the guy who is 74, who has over 6,000 anterior approach cases behind him and 30 years of experience, if he used religiously C-arm with every single case, why should not do the same? And since I start doing that, my life is 100 times better and I sleep much better. So if I can give piece of advice to anybody who's in the audience, is to try to get into the training of doing this, because anterior approach gives you that opportunity. Supine position, especially with the leg holder, it's so easy. It's literally 20 seconds of your theater time, and you having a much better results and much better understanding of anatomy as well.
Perfect. Thanks, Chuck. Another one coming towards you, Chuck, who is a difficult patient, is a 22-year-old lady that had previous, looks like SUPI or some epiphysiodesis on the greater trochanter there. Both sides, no range of motion, 22 years old, very difficult hip, difficult acetabulum. What approach would you use here? Chuck? Yeah,
I'm putting it on again. It's unfair question based on one X-ray. First and foremost, I will do the CT scan. I will see what is the anatomy of that pelvis. How does it look like? What's going on? The other thing that I see that this greater trochanter, whatever is there, that on top of this is that greater trochanter, or if it's some kind of a bone growth, I would like to know what is happening with the muscle structures, anterior compartment, posterior compartment, abductor mechanism. I would like to have more information about about anatomy of the bone and anatomy of the soft tissue before I make a decision on which approach I will use. Honestly, for attacking this problem from a acetabular point of view, anterior approach will be easy, but femur will be much, much more difficult. So it's what I can see now. The gut feeling tells me what I see here. Just purely gut feeling is telling me that I wouldn't attack this patient with the anterior approach. I will go more reconstructive from what I'm most familiar, anterolateral modified hard hinge, or I will call Uric, and two of us will do it through the posterior approach. That will be the option.
Okay, perfect. Thanks a lot. Let's carry on. Uric, maybe you can come in here. Patient, previous fracture, fixed with cannulated screws, now with ABN. Relatively difficult hip. What approach would you use?
I heard the comment made earlier that that perhaps you should not choose only easy cases to start off when you're doing a total hip arthroplasty. I certainly agree with the comment that the patient and the x-ray and the pathology should dictate your approach. Certainly in this case, it looks like there's quite significant avascular necrosis. There's also going to be significant soft tissue scarring. It's also a varus neck. As we know from the literature, it's infinitely more difficult to take on a total hip arthroplasty by the direct anterior approach with this varus type of neck. In my hands, I would certainly approach this with a posterior approach, and I try and reconstruct my soft tissues as best as possible. Having said that, I don't think that this poses a significant challenge to someone with a great deal of direct anterior approach experience. So I certainly think that it probably was done with a direct anterior approach, and you're probably going to get very, very good results. Also, I have to just reiterate, I think that you should not be doing a direct anterior approach without a C-arm. I certainly believe that you can template and follow your templating and certainly reconstruct the kinematics and the anatomy of your total hip arthroplasty far simpler and far easier. And also expanded, we know that a lot of the older surgeons criticize the direct anterior approach because you're undersizing the femoral stem. I think with a C-arm, you certainly will be able to avoid that quite easily within a matter of moments with your intraoperative fluoroscopy.
Good, thanks, Uric. Let's move on. I'll do just maybe one more. Maybe Chris, you can come in here again. Neck of femur fracture. We only do cemented, and every now and again you break your own rules and you do uncemmented neck of femur. First off, before I show you the controls, is there anything that concerns you with this patient pre-op?
Okay, so again, if you look at the spine, there's got definitely spine pathology ongoing. It's got bilateral hip pathology with arthritis in the opposite hip as well. The last thing that will complicate is got the DAA femur, or very, very thick cortices on the femoral side. We always then try to look if there's any reasons why we think this is pathological fracture. Is there any cyst in the head neck that creating pathology? But the one thing I want to say that is interesting here is that I think this is an older fracture than what it's happened, because you can see already the erosions in the middle of the neck by the neck as it eroded. So it's not a fresh fracture, it's an older fracture.
Very good. Let's look at the controls. Do it uncemented. This is what you get, intra-op.
Did you template this case?
I don't know.
So periprosthetic fractures are one of the problems with uncemented femurs. Doesn't matter what approach you used. So if you're worried about subsidence, you tend to oversize to get that fit and fill and press fit stability for immediate weight bearing. And the commonest mistake is that you overstuff the femur and you get the fracture. And then it's a spiral fracture like this one. So this is a application problem. So doesn't matter. It's not an approach problem. This is an application problem, where if you template and you look at this femur beforehand, you will not try to push a stem that fast. That's the first rule. The second rule is, yeah, I don't want to open this beehive, but I'm a firm believer in the collared corrals and that. So this is not a problem we often see at all.
Okay, if you see this, do you do a full revision with a longer stem, or just cable it intra-op as you have it there, or do you book it for the next day and do a posterior or lateral approach and do a full revision with a longer stem?
So the best revision is the revision on the table. So if I pick this up intraoperatively, I will definitely solve the problem there. So if the stem is well fixated and not oversized, like in this particular case, I will cable the femur, and if I need to, we always have a plate cable set in theater for any necrofemurs we operate on. So that will be if I think I've got stability and this is an undisplaced crack. But the moment the crack is displaced, it means the stem will be rotationally unstable, and you will have to take the stem out and do a different stem. So that you can't fix rotational instability by a cable.
Good. We're running out of time, Chris, so we'll go to your presentation. This is what was done, longer stem, just cables. There's another case, we will skip through this.
Okay, so I'm going to try to run through this quite fast. What is a learning curve? A learning curve is a mathematical equation of y, the time it takes to do a DA operation, and that's combined by the time it took to the first time, the number of attempts. This is a couple of swear words in between, and then the slope is then the acceleration of the learning curve, and a couple of swear words at the end. So in a nice scientific way, it starts with knowledge, comprehension, application, and analysis, synthesis, and evaluation. Although for orthopedics, it doesn't mean a lot. So this is more how a learning curve looks if you start any operation. You first do it, then you sit down, it doesn't work for me. Then you meet someone, then you think, yes, I'm great, I can do this. And then it goes down again. So there's quite a lot of this up downs. This brings us to the Dunning-Kruger effect. It's something we talk quite a lot about. And this is how you becomes an expertise in your field. You first have this increase in confidence, and then you end up at Mount Stupid, where you think you can do things. Then you very quickly fall down into the valley of despair, and then wisdom appears, and you get the slope of enlightenment. And hopefully you get to a plateau of sustainability. So that's what the learning curve is for any operation. In fact, the Dunning-Kruger effect more looks like this. So you've got a very rapid Mount Stupid, valley of despair, and then there are second and twin peaks, and then you go on the corrugated roads of life before you go to your slopes of enlightenment and expertise. And they always say experience, you can't buy experience. You actually need to go through it. So if you talk about learning curve in orthopedics is a hot topic over many years. And one of the topics is super specialization. So super specialization is there to actually limit learning curves for any subspecialty field. These authors were pediatric authors that talk about DDH, and they were very strongly opinion that some cases must only be done in a fellowship trained person, and then in the fellowship surgical mentor, you must practice on cadavers, and you must have good training, and then the learning curve will be reached during your fellowship period and not after while you treat patients. So even for a simple thing like a supracondylar humerus fractures, for a fellow in orthopedics, the average learning case is 15 cases for average supracondylar pediatric fracture. If you go to robotic knee surgery, also a lot has been written about learning curves for robotic knee arthroplasty. And they say if you really know how to do a total knee replacement, you already learned that technique, you know how your prosthesis work, and the only thing you add is the robotic function. It still takes you 20 cases before your theater flow and your surgical time is equal. So the moment you introduce a new technique or a new prosthesis or a new approach, there will always be this learning curve, and it depends on your prior experience what the learning curve will be. So this is probably the most quoted, cited article on learning curve for anterior approach hip surgery. This was done in Australia. It was done on the positioning table on a single type of implant. And in this and it gets quoted all over the world, that under 50 cases, the complication rates goes above 2 to 3%, but the moment you reach the target of 50, it becomes equal to any other approach, as well as to someone that's got more than 100 cases. So the problem is this 1 to 15 that's got a 300% increase revision rate, and 30 to 50, which got like a double complication rate to the surgeon that only performs more than 50 and 100. So it is definitely like Gary Player will say, the more I practice, the luckier I get. But the more you train muscle memory, the better you become with this operation. So 50 is the magic number that people talk about, and that's doing the table position of DAA surgery. But for other hip surgery, this is a very also interesting article that looked at registrars and fellows, and they would say for cannulated hip screws, it's at least 15 cases before something happened and you start becoming more consistent. For unlocked femoral nails, 20, locked femoral nails, 30, and hemiarthroplasty, 25 cases. And if you look at how a surgeon will operate, it always goes up and down. So and this is because no two patients are the same. Patients have different complexities. Surgical conditions are differently. You operate in different times of the day and the night. Sometimes you operate on a Monday morning and you might have had a busy weekend, or you operate at the end of your day. So there will always be these things that you cannot compensate for. It's important that we must do our training and design our training so that we accommodate for learning curve. This is quite a shocking thing. They were saying for arthroscopy of the knee, if you do simulation training and you want to achieve the level that a consultant, experienced arthroplasty or arthroscopic surgeon is, you must do at least 170 procedures before you get this skill. So for arthroscopy, so it's much more than the 50 we talk about for the hip surgery. This is a very good article that you can read. It's actually quite old already, but it talks about the different ways that we teach and train orthopedic surgeons these days. And it's advised that we move away from just surgical skill laboratory, synthetic bone and cadaveric specimens. And then virtual reality was hampered in the past because of 3D haptic feedback and a shortness of software, but this has now been nullified. So today, virtual reality training is very prominent for arthroscopy, and this is arthroscopy virtual reality training platform and arthroplasty. So, and it all comes down from flight simulator. Initially, flight simulation was quite old and was difficult to get this 3D picture of what's going on around you. They tried various methods with TV screens all around you. And today, it's completely different. You're sitting in this airplane and it feels like you're really there. If you turn your head, you can see it. And that's all due to virtual reality platforms that has expanded massively. And the training from this has also opened up new things. So here, this is a very good study last year, 2019, from JBJS, where they test registrars. So they took registrars that already did 20 joint hip arthroplasties through the conventional techniques, either anterolateral or posterior, but none of them have ever seen or done a DAA hip surgery. So the one group, they then give this virtual reality training goggles, and they make them train of this. And the other group, they give the conventional surgical training, talks and discussions, and dry bone workshops. And then they bring them together and then they operate them on cadavers. And they had to measure objective things. So they measured this procedure-based assessment, that's a British system, to see that how accurate you are. And in all the things, the guys that were operating with the virtual reality, they were able to perform this operation as a 3A, a 3B, or a 4A, with almost minimum or no supervision needed, while everybody that had the traditional training methods of a surgical technique that's printed, a dry bone workshop, they had no idea, and it took them a lot of more help to get to the same point. It took them much longer to get to the same point, as well as they didn't know the instruments as well. That was the application of the instruments. So this is really quite profound. And in this study, they found that 8 virtual reality surgeries were enough to actually learn the learning curve, and therefore the application into a cadaver was actually quite smooth. This hasn't tested the transition onto human patients. So, but 8 of those, so that's 20 minutes times 8. you can actually learn and get a lot of the learning curve of the operation out of your head by doing this on a virtual platform. So we've adopted it quite vigorously in Tygerberg since last year. Here you can see Mark Norchi that came across the XK. We had different surgeons. Here's Prof. Nando Ferreira, Marie from Pediatrics, all doing hips and knees on a virtual reality platform in Tygerberg Hospital. And you could see how quickly, because in this case, you read it, you hear it, and you do it. And the uptake of the surgical approach are so fast. And here I actually got a video of my two sons. I mean, he's the instructor now because he's as fast as I am doing this virtual operation. He's 10, his brother is 6. He's doing the operation here. He can do it without me telling him what to do. And I promise you, there's a little rascal here at the bottom. He's 4 years old, and he's also been trying a hand and hip replacement. So if you can learn someone the skills at that level, just think of what happens if you're a hip surgeon and you learn it that way. It's actually very fast to pick up with this. The other thing that we underutilize is 3D printing. So here's a 3D case we printed in Tygerberg for Prof. van der Jacht. We did the live surgery. It's just different if you do this templating of the case and you can actually do the live surgery on the models. But then we also made Prof play some games and see that he can do then the DAA hip surgery through this platform. So if there's one thing that I want to tell you that's worth investing in training people, it's virtual reality. So we presented this last year at the Congress of our experience based of complications, and you can see quite high complications, but we count everything we could. We were like as honest as we can. And you can see then of the anterior approach, the 221 we did that year, me as consultant has only done 20, 41% is done by the fellows, and the rest of the 40% is done by senior registrars or junior registrars. So a large amount of them has been done by registrars. So in Tygerberg, every registrar perform DAA hip surgery, and often alone also after they become experienced. And you can see our overall rates for the consultant. I normally do the more complex cases, the chronic cases, or things where there's pathology of the bone. So I had quite high complications rate. But the junior registrar had almost the same complications as me because I was always there in theater. We had this training model with them where we actually go through them and they don't harm the patient. So we can perform the operation safely by having an experienced trainee with them in theater. And that nullify the learning curve quite significantly for these registrars. So in summary, from a learning curve point of view, there is a learning curve to any operations that you want to do. And there's no exception if you do the anterior approach. There will be a learning curve. For the registrars, after about 10 cases, I can safely feel they can do this without me in theater, without being a fellow in theater. Then the two registrars can safely perform it alone. So that's a rough guide. But for the registrars, the learning curve is very small and with low complication rates because they are supported by senior surgeons all throughout the process. But if you learn this outside of a training institution, that's where the problem gets going. You see it once, you want to try it once, and then when complications happen, you don't know how to deal with that. So a golden rule that I was told, if you change your approach, don't change your prosthesis. Don't change multiple things because then you don't know what is causing the problem. So if you want to venture into anti-hip surgery, you must be able to do it with the implants that you currently use. The moment you change the approach and your implant, you've got two variables and both of them can actually lead to disaster. And I feel very strong that virtual reality training is the future. It reduces the learning curve significantly. It reduces complications to patients, and it creates this cognitive bandwidth. So if you know the procedure very well that you're going to perform, you have time to look at your x-rays, you have time to look at your soft tissue, you have time to look at your cup position and placement.
Thanks, Chris. That was very nice. If I can quickly ask you, did you ever think of reverting back to your previous approach because of problems you experienced or lack of support from guys around you? And at what stage is it usually? Is it at 5 cases? Is it at 50 cases? Did you want to revert back to your old approach?
It's a very good question, Hans. So the first thing is Henny Bosch here, he told me one day that he will stop to try convince people to do anterior. He won't. He will just tell them what is his experience. And for me, that's the same. I'm not trying to convince anyone they must do this. I'm actually on the other side feeling like maybe someone is not good enough to do it, so they'd rather stick to the old approaches. I know that's bad to say that. So when I started, we were 2 surgeons. It was me and Gian de Prier. And if it wasn't that the 2 of us did the training, a full week training together, and we operated the first 20 cases together, I would probably never have gone this route, because it was difficult for us as well. But we were 2 surgeons together in this. It was not alone, and that's after a full week of training with this. Now I will never go back. The DA is there for me to stay forever, and I will train everyone because I believe in it. I really believe in it. But like we said, everyone said, I've got 2 approaches: a posterior approach for some cases, DA for some cases. The one thing I want to add, and I'm saying too much again, is remember, if you age, we talked about the long-term follow-up of patients. So there's 2 things. So muscle heal by fibrosis. So the moment you cut a muscle or a tendon, there will always be fibrosis. And the DA is the only approach where you don't cut any muscles or tendons. And the MRI studies done at 5-10 years shows actually pristine musculature. So that's the one thing. The second thing is, as you get older, especially your elderly population, you lose muscle, you become sarcopenic, so you've got loose joints. The other thing is you get a positive sagittal balance. You've bent forward with your wedge compression fractures, and you become seated at some stage into wheelchair. So your posterior dislocation risk gets more by just sarcopenia, as well as positive muscle balance and positive sagittal balance. And in both those cases, the anterior will give you a better long-term results than the posterior.
Chris, we got a comment from one of our faculty members, Lipolo. Can you hear us?
Yeah, no, I can hear very, very clearly. Can you hear me?
Yes, we can hear you.
Yeah, so thank you very much for the opportunity, and really a really fascinating discussion. So Hans, as the chairman, so earlier on, you asked a question about the DAA, and the way you phrase the question. So you phrase the question essentially to say that there doesn't seem to be any long-term differences between the DAA and other approaches. And I thought to myself, but why are you even phrasing the question that way? Why are you not phrasing it the other way? Are there any differences in the short term? And I think there's enough evidence to show that certainly in the short term, that the DAA, the patients rehab much quicker. It is less painful as an operation. And essentially, as we continue to push the envelope, as we continue to do operations where patients come in and get out much quicker, day surgeries, you have to then start looking at the short term as well, because as you get older, you also start to personalize a lot of these things, and it stops becoming what would you do in a case, but rather what would you rather have done in you. You understand where I'm coming from? So if I had a hip replacement and long term, there were no differences, but if you did it in a certain way, I would get my independence much quicker. I can tell you that 100% of the time, I would go for that option where I get my independence much quicker. And the other issue is you also have to appreciate that there is collective experience that we're learning from here. So the guys that started the DAA, even here in this country, certainly in the beginning, they had a lot of complications. But the guys that are starting the DAA now have benefited from that collective wisdom and experience, and they're getting less complications. So in time, my prediction is that the juniors that are now trained effectively through the DAA, there will be absolutely no difference, but all the advantages for the patients, because in terms of the complications, the complication rates,
They will be the same, but the early outcomes will be superior. What happens later on, if it's the same, no issues, but ultimately, overall, the patients will benefit.
Thanks, Lipolo. Now, I was just playing devil's advocate there with the posterior approach guys always asking, and actually one of our audience members also asked, what is the long-term benefit? Yeah, the short-term benefit we all know is quite significant with day surgeries and early mobilization. So yeah, but it's good to get feedback on the short-term, but it's always a good question from the posterior guys is what long-term benefits there are, and it's good to explore it. Thanks. Johan, maybe you can comment on that. When do you use a dual mobility cup? Do you ever?
Yes, and so more so than not in some of the difficult neck or femur fractures that have got a failed fixation. So that would be my go-to, is to have that in theatre at least. So these failed DHSs with AVN that have had multiple previous surgeries, I would have that as a standard. And then also the patients with spinal pelvic disproportions. I mean, the patients that have got previous spinal fusions that are stuck in either sitting or standing. So patients with stiff pelvis and hip relations, I would definitely have that as a backup. As well as the patients with intertrochanteric fractures. I think we're pushing the envelope a bit with doing total hip replacements for some of those patients. So I definitely would have dual mobility and a cemented stem for those type of patients.
Good. Yuri, lastly, maybe tell us how often do you use the dual mobility cups? And then secondly, do you do hip replacements for intertrochanteric fractures or basal cervical neck or femur fractures?
Thanks very much, Hans. So as per routine in our institution, all neck or femur fractures get a dual mobility cup. We routinely put 2 screws into the acetabular component, and we cement all of our neck or femur fractures. I think the data is out there and the research is conclusive from a 2018 Journal of Arthroplasty paper, which shows that a routine dual mobility prosthesis does decrease the long-term costs. These are old, frail patients who have a propensity of falling, and certainly the cementing does decrease the rate of periprosthetic femoral fractures. What was the second part of your question?
No, it was dual mobility, using dual mobility cups, and the intertrochanteric fractures or basal cervical neck or femur fractures. Do you ever do total hip replacement on them?
So the answer is we try and fix first and foremost, but certainly yes, we do do a certain proportion of our patients, especially, and I think the most important thing is to have a look at what's happening in the acetabular area. If there's any degeneration, then certainly we would obviously replace rather than try and fix.
Good, thanks a lot, Yurik. Before I think that's enough for tonight. We're going to go over the time for. We've had a very nice discussion. I want to thank my panel. You made it very easy for me. Your insight to this topic is very good. I've learned a lot. I hope the audience learned a lot. And I'm really looking forward to the rest of the series. So to my panel, thanks guys. The information you gave us was pretty interesting, and hopefully the audience can use it forwards. Michelle, over to you.
Yep, just simply to say thank you to everybody. You really done a sterling job this evening, and I think there was some really lively debate and some excellent questions from the audience, and we hope they were answered well. And certainly I'm sure there's an opportunity in the next 2 episodes to answer more questions or to answer them more deeply. So thank you everybody from us. Have a good evening, and a special word of thanks to the panel. Thank you.